Hey everyone, welcome to So-Called Normal. I'm Mark Hennick. Today on the show, we have Dr. Brian Goldman. Brian is the host of White Coat Black Art on the CBC. It's a really fascinating, long-standing radio show. He's also an emergency room physician. And as we talk about, you're going to hear in our conversation together, when I was preparing to do my TEDx Toronto talk in 2013, Brian's TEDx Toronto talk, which he had done, I think 2 years maybe before me, was one that I watched pretty much on loop. I watched it over and over again. The stories that he tells in his TEDx Toronto talk are compelling on their own. But I loved the structure of it. I loved his storytelling style, his personable nature, his use of, this is all geeky professional speaker stuff, but his use of callbacks, how he sets up something in the beginning and then brings it back at the end. It was just such an emotional and authentic presentation that his and Brene Brown's were probably the most influential in the development of my own talk. So we talked a little bit about that and his life and what brought him to do what he does today. Really fascinating guy. His book is out on April 24th, my birthday actually. So this week you're going to be listening to this on Monday. My birthday, I think it's on Wednesday, maybe. I think that's 24th. Anyway, whatever. After a certain age, you start to lose track of time. Anyway, that's not important. What is important is that you're going to really enjoy the conversation that I had with Dr. Brian Goldman. I know I sure did. So without further ado, here's Dr. Brian Goldman on So-Called Normal.
I grew up in North Toronto. I would say I came from a Jewish middle-class family, probably tending to the lower middle-class side of things.
But your parents weren't physicians?
No. First doctor in the family. I guess on my mother's side. On my father's side, I had two much older cousins, one a family physician, one a neurologist. Mm-hmm. So basically, grew up in Toronto, overachiever. I remember in high school, one of my classmates said that Brian Goldman would study for a blood test.
So why? What do you think? Were you trying to impress? Was this an expectation of your parents, or was it just your personality?
Complicated question. A lot of therapy. Complicated question. It was, I guess, partly it was peer pressure. I have a competitive streak that sometimes gets me into trouble because it plays against that calm. You can't be calm. Well, I can't be calm when I'm in the midst of my competitive streak.
Right.
So, what makes me run? I don't like to be an also-ran. I like to be noticed. Mm-hmm. I guess that's it. I don't have to finish. In fact, I'd be scared with the pressure of having to finish first all the time.
Right.
It's interesting. I've never thought of it that way. I've never identified with the people who get the gold medal, right. Who finish first, in medical school. But I want to get noticed. I don't want to be forgotten. I think that's always been, So if I look at a list of acknowledged people, I'd like to be on the list. I'd like to not be forgotten, and as if didn't matter.
I don't think it takes a psychiatrist to figure out the radio show connection then, but we can get to that maybe because that you've become probably one of Canada's most prominent doctors, if not the most prominent doctor.
Right, and that's a really interesting thing because we can segue into that anytime you like, but one of the things about that experience is that, well, okay, so how can you get when you're not aiming to be the best?
Right.
And I'm into my second marriage. This one's for keeps. My first marriage, one of the best parts of that marriage was the relationship I had with my father-in-law, the late Dr. Martin Jeremias, who was a urologist of some note in Hamilton, and he had these came from Hungary, Hungarian Jew, had these lovely aphorisms. The most important ones he left me was, if you can't be the best, be different.
Right.
And that was
That's great advice.
That was my and that's been my mantra all the way through. So hosting the radio show, I became the emergency physician who hosts the radio show,
Right.
who has this other major interest. Now I'm not the only one.
No, sure.
There are plenty of physicians who do other things and do them quite well.
Right.
But
well, let's go back to that a little bit then. So you go off to med school first at least on your mother's side of the family, to do that.
Yeah.
Here in Toronto, you went to?
Here in Toronto, went to U of T, University of Toronto, and to be candid, I think I went into medical school certainly not to save the world and not to cure a disease that killed a member of my family, but rather because that's where the smart kids went. I was driven to succeed, but I wasn't driven to a particular purpose. I was probably more oriented to the arts, to writing, to English.
Yeah.
Maybe I could have been a screenwriter. I could have been a writer of fiction. If I worked hard enough, I could succeed in math and the sciences. To me, it felt as if I had a choice. Mm-hmm. I remember there was a friend of my parents who used to call me, when I was 10 years old, call me the lawyer.
What does that mean?
The lawyer.
Oh, the lawyer. Oh.
The lawyer. Yeah, that was his accent. He called me the lawyer. And he was, and he, because I was an arguer, because I could argue. And I was probably one of these smart ass kids. No, I wasn't probably. I was one of those smart ass kids who could talk back. Right. But I wasn't, I get threatened sometimes by young kids who it took me a long time to feel secure enough in the presence of a quick-witted person who could find contradictions.
Right.
And I had to get a lot older and wiser to be able to do that. In fact, when I'm kind of pinned to the wall, when somebody's going after me like a prosecutor, I can get stressed out.
Sure.
And tongue-tied, and I think one of my worst fears is that I'm going to blow the moment.
Right.
And not deliver the coup de grace, and now I think of it as the kill shot, which is a terrible thing. I don't actually want to deliver the kill shot. Now that I've written a book about kindness, I shouldn't. And you know what? It didn't suit me, and I didn't enjoy it. But I can tell you right now, I'm flashing back to being an expert witness on a witness stand and a very good defense lawyer delivering a kill shot to me.
Yeah. And
what that feels like. And, he was doing his job. He was defending his client.
A kind of insult to ego in some ways, I guess, or whether it's making you feel like you didn't win. Does it come back to the competition thing that you couldn't best him?
Or is it shame? And it took me a long, long time and a lot of hard work to realize just how shame-prone I am. Sure. And I think that's one of the major reasons why I became what I became.
Right.
And why I recognize it in other people, because I am shame-prone.
Yeah, absolutely.
I think anybody who's as defensive as I have been in my life, it's taken me a long time to not be as defensive. You recognize it in other people. Hypersensitivity to criticism, as if that criticism is destroying you, as if what they're doing is they're trying to destroy you. And I guess some people do. In the culture of medicine, there are people who are absolutely trying to destroy you with a line, and they for whatever purposes they have. But I had to realize my own shame-proneness,
right?
And that was becoming a physician and discovering that as a human being I could make mistakes. And
I'm relating so much to what you're saying, and I always just blamed it on my Irish Catholic parents. But did you ever spend any time blaming it on your Jewish parents that you felt all this shame?
Not until last night.
and not until I just said so. No,
not until literally,
really?
One of the things about Twitter that's wonderful. I mean, there are lots of things that aren't so wonderful, but one of the best things about Twitter is that you get the wisdom of the universe,
right?
Just coming back at you.
Right.
And a man who I have immense respect for, one of the people I follow, he follows me. He is a recovering alcoholic, and we got into this wonderful conversation about shame, and it was all based on, I did a column for CBC Radio, why do patients lie, and it's a hot button topic because first of all, disclaimer, I lied when I was growing up. And I can tell you today, if I'm confronted, I lie. Right. Because I don't want to be shamed. I'll do anything to duck out of that.
Yeah.
When I was 8 years old, I was confronted. I had a hole in the crotch of my pants, and my white underwear were showing. And when I went to gym class, I realized it, and I was on the verge of being mocked severely for that if I pranced around the room. So I cowered in a corner, and then the teacher noticed, and she kept motioning me, come, do this, and she saw this as disobedience, and so she stopped everything and schlepped me to the middle of the room, where I could either tell all my classmates, tell her that I had a hole in the crotch of my pants and my white underwear were showing, and I could tell everybody why I was so ashamed, or I could prance about and show everybody why I was ashamed. And what did I do? I stuck my tongue out at the teacher. So I'm always looking for door number 3.
Right.
I'm always looking for. I don't like it when an angry, stern person confronts me. I'm basically a good person, and I just don't like it. I can tell you when I get stopped by a police officer. Same thing.
Yeah.
Customs. It's the same. The authority figure who, it's as if my worldview is I won't be able to talk my way out of it.
So then all of these things, and for some reason, I don't know why, I wasn't entirely prepared for you to be so candid, but it's great.
Be a mask.
Well,
I was going to wear the mask. What's the point?
Well, and this is it. So you talk to a lot of doctors, and I have both in my career, and I think of it as a career as a patient of the mental health system when I was a teenager, and then later on working in advocacy and trying to understand the system better. You get used to doctors being a certain way, carrying that authority, and really, not your whole shtick, but a lot of what you've done has been dismantling that. And,
yes. Yeah.
You've mentioned shame, and one of the main reasons I wanted to have you on the show was because when I was prepping for my TED Talk, for my TEDx Toronto talk, there were 2 other talks that I listened to on loop that inspired me. One was Brene Brown on shame, and the other was yours.
Thank you.
It was an extraordinary story that you told, this idea of being asked if you remember this patient who came in. Can you share a little bit about that for those who haven't heard it?
The 3 worst words that an emergency physician will ever hear are, do you remember? And it's funny because nobody ever said it to me, but if you say it to other people, they just sigh and they just slump because we provide episodic care, which means that in the emergency department we provide care to patients we don't know. We don't know their backgrounds. We don't know if they are hypochondriacs, if they exaggerate their symptoms. So on the one extreme, you have that. And on the other extreme, you have somebody who only seeks medical attention when they're 5 minutes from death.
Right.
And they don't. You can't tell. Sometimes you can't tell. You can tell when somebody's an extremist, and you develop an ability to recognize that. But there's this whole cohort of patients who could be a day from death. They could have they could be basically okay, but you don't know that there's a time bomb in their head. They're sort of not complaining of the headache. It's the burst aneurysm. It's not the migraine. It's the burst aneurysm. It's the sentinel leak, a little leak of blood. That's your best shot to find the aneurysm and clip it. Or get the neurosurgeons to clip it before they die, before they get the big bleed where they're just going to have an intracerebral hemorrhage and it's going to be a disaster and they're going to die. Or they're going to be so brain impaired that that their lives will never be the same. Their families will never be the same after that. And we get all kinds. And we see them. We treat them. Patients don't know how to describe their symptoms. They don't know the vocabulary that we have. It's all written nice and neatly in the books, and then you go out and practice and you discover patients don't talk like textbooks.
Well, and you had one of your previous books was on doctor jargon and lingo. I think the one that stood out, I think it was from your book, Pumpkin Positive. Was that from your?
Oh God, well, that's British, and they are the Brits have way more slang than Canadians and even Americans. They are wicked. They destroy you with words.
Yeah,
and anyway, so the idea is that you see the patient, you provide your best advice, and you're bringing your experience to bear. You may have problems in the system where you want to order a test and it's hard to order it because you have a cranky radiologist and you've already bothered them twice before. You don't want to call them again for yet another CT scan. So your mind starts to play cognitive tricks with you. We all make these cognitive errors, and I didn't know. We didn't know a lot about those at the time. long before I did the TED Talk.
Right.
And then, you send the patient home. And then, you go away, you think everything's okay. And then maybe 2 days later, you come back for your next shift. And a colleague says, or a nurse says, do you remember that patient? And so in the TED Talk, I described it, and the do you remember is I've yet to have a do you remember experience that goes, well, he's so happy with the way you treated him. He's donated $1 million in your name to the hospital. It's usually because they came back. On that was the impetus for not only for my TED Talk, because I wanted to describe the experience to other people, but also that was the impetus for White Coat Black Art. Right. I wanted to pull back the curtain and get colleagues to talk about that do you remember moment.
Yeah. Your CBC
CBC
radio show.
Yeah. And Bruce Campana did it. He talked about a man with autism spectrum disorder, who was about 30, developmental delay, living in a group home, and would periodically come to the emergency department complaining of constipation. And he described him as a flailing man, screaming, and with his attendants, and the nurses saying, can we just give him an enema and get him out of here? And they did that. He did that. And then he came back for his next shift, and the do you remember was that he had died of a ruptured appendix. He had appendicitis. And this is the stuff that keeps us awake,
Sure.
And when it happens, and I described that in the TED Talk, this feeling of, I can't even describe it. You can't sleep, you can't eat. You are, it took years for me to find the vocabulary of shame, which I didn't have in that TED Talk. Brene Brown talks about it. Now I know all about it.
Right.
Now that I know it, I see it. That's what I was describing. I was describing that abnegation, that desire to have a big hole open up in the earth and swallow me up.
Right.
And I had no thoughts of suicide, but I did have. I didn't want people to see me.
Sure. This disparity between what you did and what you think, or what you should have done, or what your morals are, or what is it?
Oh, well, I described the mistakes I made with the first patient, with that patient that I described in the TED Talk, which is the one that's indelibly in my mind, a woman in her 80s who I saw. I was the resident on for cardiology. I saw her in the emergency department, treated her congestive heart failure, and sent her home without talking to my staff, without clearing it with my attending. I did it despite the fact that I had doubts, and I even asked a nurse if she thought it was okay, which should have been an indication to me that I wasn't sure of myself. And I sent this woman home and went to do my other things in the hospital, and at the end of the day, my instinct. I walked out of the building in a completely different way. I walked through the emergency department on my way out instead of the shortest route to the parking lot. And a nurse said, "Do you remember that patient you sent home? She's back." And she was near death. And she died about 10 days later in the intensive care unit. It was a horrible time. I can only imagine what a horrible time it was for that family. The look on the attending's face when he asked me what happened, like he flinched, like this look of pain when I told him. And he, I said I wanted to talk to the family, and he said, "No, I'll take care of it." And he did, which was not good for me. I needed to own up to it.
Did you ever end up talking to the family, or how did you reconcile that?
I didn't. Yeah. I didn't reconcile it. I've carried it with me to today. The best I can do is talk about it.
Right.
It happened a long time ago. Sure. And we're talking 30 years ago now. But it stayed with me. And at that time, in the culture of medicine, I think there's this belief that the person who did it, showing their face, would somehow make things worse. It's a different time. Today, in the intervening years, I've learned the value of an apology.
Right.
That very often families, people just want to know what happened. They don't want to be told. They don't want to be given the "we did our best" and just this wall of rationalizations coming up, and instead of, and they feel as if they've hit a brick wall, and to them it's like a second trauma.
Right.
The first trauma is what happened, and then not knowing what happened is the second trauma, and being isolated. And that often happens, when something bad has happened with a patient, now they're in the intensive care unit and they're lingering there near death for weeks, that the attending, the team doesn't talk to them because they kind of throw a wall around them. And that's, I can't make that one go away.
Right.
What I can do is pay it forward, and so what I'm trying to do is get people like me, get people in the system to acknowledge that shame begets secrecy, and secrecy begets nobody knowing about mistakes and nobody fixing them.
Well, and this is it. And it's also not just a self-regulated thing or a self-flagellation for the rest of your life, that the hospital has memories, the community has memories. And you gave this great example of going to a party with the other doctors, I think, and you knowing which, or everybody knowing which one cut the wrong leg off a patient, and everybody knowing. So everybody knows, or not, maybe not everybody, but a lot of them know each other's mistakes and foibles and slip-ups, but it's kind of an unspoken shame, it seems.
Oh yeah, and you could look at that two ways. In one, it could be Schadenfreude. It could be, and I, in my kindness book, I was going to have a chapter on Schadenfreude. Feeling pleasure at somebody else's pain, and or the sense of, and there are many reasons for that. It may be that you have low self-esteem, and you see this as an opportunity to cut the other person down to size, and so now the gap between us isn't so great. And I think that I'll cop to that if a colleague shamed me once about a mistake, and then they found themselves wrapped in their own trauma from their own mistake, it would be hard for me to suppress that urge to say good. Good. But you know what? The fact is that could be the moment that the two of us reach out to each other and you say, you know what? I've been there. And one of the ways to repair a relationship, if you do have a relationship that you don't think is as good as you'd like it to be with colleagues or family members, extended family members, is to be unexpectedly kind to somebody,
right?
Or acknowledge something that they do really well where they didn't see it coming. They didn't see you ever doing that. And it's.
I was talking to somebody a few days ago about. There's these scripts that we follow where everybody is supposed to be kind to each other. The hi, how are you doing? Oh, fine, thanks. And nobody actually even hears any of it. Right. But then when you step outside that script, that's when it actually gets noticed.
Yeah.
So have you had these kinds of experiences in the ER where you're unexpectedly candid or vulnerable or honest with a patient, and and you notice that really breaks down a wall with them?
Yeah, it's risky.
Sure.
It's very risky because the danger is becoming enmeshed in the patient's life, or having them perceive that they have become enmeshed in your life.
Right. You're trying to be empathetic, but you're not trying to be their friend. Right.
Right. But not to completely destroy what you're talking about. By going to the and we do this in healthcare all the time. We always go to the extreme example that tells us that you can't possibly be right.
Right.
On the other hand, Brene Brown said, and that TED Talk was about being vulnerable.
Right.
And when I'm vulnerable, it's the riskiest thing that I do, especially in healthcare, because in the healthcare culture, because if you are vulnerable, you may get a kill shot.
Sure.
On the other hand, if you're vulnerable in the right time and place, certainly with patients, they may understand that the leap that they may have to make, the chasm they may have to cross, the mountain they may have to climb, that is, may not be as impossible as they thought it was. I'm thinking right now of a young man who came in as the identified problem, and he was, he was in a young family under stress. They had 3 kids. He and his wife had 3 kids in very short order. They were all under the age of 5, and they were having financial stress. And it was it would have been so easy to just identify him as the abusive partner, and he had been somewhat physical. I don't think there were any severe injuries. That doesn't matter. It's still not right. Mm-hmm. And I made a connection with him. Mm. I treated him as a human being, talked about, gave him space to talk about the stresses that he was under. Mm-hmm. And the sense I remember from that encounter, the sense that his life had lined up, that too many ducks had lined up too quickly, too many kids, married. Like, in fact, the first child he got married after his wife got pregnant. Mm. And you got the feeling that there might be some regret there, that they'd gone far down a road towards, now they have this family. We have a complete family now. And I'm not sure that this was the life that I ever intended for myself. Right. And you should understand that the details that I'm talking about are not the kinds of details that emergency physicians usually get.
Right.
In the context of an emergency visit, it's usually, do I need to? Are there injuries in that case? Are there injuries I need to treat, or are you suffering from a mental health condition for which I have to consider putting you on a form? Right. He wasn't. He was he was compos mentis. He wasn't intoxicated.
But this is increasingly common. I mean, the emergency room is almost the frontline treatment for mental health crises.
Oh, yeah. Oh, it is. Absolutely it is, because there aren't a lot of other available services in real time that are effective.
Right.
And it's not just them. It's teens, especially, young adults. Life is complicated. I think there's chronic stress, time pressure, fear of missing out, all kinds of stuff like that.
One of the things that you hear pretty consistently from mental health patients of the mental health system is that they feel that service providers, that healthcare professionals, are the most stigmatizing. Now, you would think that people who work in the healthcare system would have an empathetic understanding of what people are going through, but that's not really the case. And the way that I've rationalized it in my mind is that, everybody just wants to get home to their kids and have dinner, and so they categorize and they work through, and somebody's in for the 7th time, and that's the frequent flyer, so it can't be anything this time, and then a tragedy happens.
Right.
We hear about this all the time. Mm-hmm. So how do you? I mean, you must have encountered, probably still do encounter, people who are suicidal and mental health crises all the time coming into the emergency room. How do you break out of that script? How do you be the one who gets that connection with them when it's so easy to not?
Well, and then how do you do it in the amount of time that we have to do it, which is not a lot. And although as I said in my book, In the Power of Kindness, I don't think you don't need a lot of time. Yeah. To be empathetic, to establish a connection, but you must be free of all the other pressures at that moment. You can't have 5 competing demands and be empathetic.
Right. Which, I mean, sounds like kind of a tall order, though, for
very tall.
Somebody working in an emergency room, right?
Okay. I think experience is a good teacher.
Sure.
I think you have to run the risk of saying things like cut the bullshit. Mm. Almost every emergency physician goes through the experience of doing assessments and assessing a patient who talks the talk of suicide and sending them referring them to the psychiatrist, who then sends them home.
Right.
How did that happen?
Right.
And we have these two competing views of healthcare, of how we assess patients and treat patients. One of them is establishing a connection, and it's a unique connection, realizing that all patients are different. That's on the one extreme. On the other extreme, it's the algorithm.
Right.
This is how you do it.
Do the blood test.
Bang. Yes. Blood work, routine blood work, ethanol, salicylates, Tylenol level, urine detox, urine drug screen, and if they have a head, if it looks like they've bumped their head, get a CT scan of their head, and then send them to the psychiatrist, and then they'll do the assessment. This kind of cookbook approach, and I must say, some of my colleagues probably don't find that dissatisfying at all, but because they package and process the patient and away they go, and put them on a forum.
People routinely in all psychiatric facilities have really negative experiences sometimes.
Of course they do, and that's why peer support workers are so important. And by the way, newsflash, if I didn't host White Coat Black Art, I would never have heard about peer support workers. Right. And it's interesting because my colleagues don't relate to the fact that I host White Coat Black Art.
Oh, really? So I wanted to talk to you about this. So what's that like then for you, being such a prominent public figure, a public intellectual, and then still being a working physician?
It's increasingly challenging.
Really?
I would say. I certainly, patients recognize me and families recognize me, and so I have to compartmentalize that. And I'm operating as a physician and I'm acting as a physician, and I try to, I very quickly show them that this is the Brian Goldman physician version. And on the other hand, I couldn't host the show if I wasn't steeped in the culture of modern medicine because I would be out of touch. And if I'm out of touch, it's going to be very hard to host that show.
You've spoken very candidly of many issues and critically but I think constructively of the healthcare system and of physician culture in particular. Have you received any kind of blowback from that, from your community?
Yeah, occasionally, but usually in medical culture, it's we handle that with silence. We never say a word,
right?
But we just keep the thoughts in our mind, and I think that there is a gap. The gap is that. I think that a lot of healthcare professionals are perfectionistic, and I think they're perfectionistic because they have this core of shame proneness. And a lot of people are people might listen to me saying that and saying he doesn't know what he's talking about.
No, but there's a couple of hospitals here in Ontario, through the Ontario Hospital Association as well. They've done some work on this, looking at the zero suicide movement, striving as they did in the Henry Ford Health System, I think, in the States, to have a zero suicide rate in their hospital system. Some physicians have pushed back against that because it feels like it's you would think on the one hand they're perfectionists, sure, but then on the other it feels like they're being accused of failing, or it's setting them up to fail, even though it's an aspirational goal. So you can kind of see both sides of what you're talking about there.
And anyway, I think that shame proneness is an underlying feature. Right. An underlying characteristic. And and by the way, I need to answer this question. Is shame genetic? Yeah, it can be. And that back to that Twitter follower who is a recovering alcoholic who said he thinks it's genetic. And I remember, I think my mother was very shame prone. And I think my parents were both shame prone. I think I got a double dose of it.
Right.
And so what has that got to do with healthcare professionals? I think a lot of them become healthcare professionals to do as many good works as they can to try to make up for that one mistake they made when they were younger, or that feeling that they're not good enough. And what I'm talking about are people who never say no to another request to be on a committee, to do another research project, to do another special project, and they are I've been a collector, like a vacuum cleaner collector of aphorisms and phrases about this all of my life. People who are known not as human beings but as human doings,
right?
Who are just known for all the things they do,
right?
But I wonder how they feel in the middle of the night. What wakes them up in the middle of the night? Do they sleep soundly? Do they sleep like a baby? I don't. I haven't slept like a baby for ages.
Right.
Since I was a baby.
Sure.
And the other thing I wanted to say about that is that it's a core of insecurity. And as long as they don't make the big mistake, they are smart.
Right.
And perfectionism is a goal. I don't think it's an achievable goal, but it is a goal. And they are smart enough that they make fewer mistakes than other people. They're hypervigilant, and all may be fine. They may go through their career, but then if fortuna or whatever, a momentary lapse, or they're tired, or they've taken on one task too many, and the big mistake happens on their watch, they may be devastated by it. The weirdest thing is that this could happen to somebody in their 50s, where they've had 25 years where they have top of the class,
right? And
they've never made a mistake, and
or at least they never heard about it,
or that they never. Well, that's right, but because it's all about, if shame is about secrecy and silence, and I think now the movement says we're supposed to talk about our mistakes, but remember, you also have lawyers who are telling you that I'd be a bit more cagey than that, and if you find yourself as the only person in the room talking about your mistakes, then you're the only person who makes mistakes.
Right.
In some
and as a result, we see rates of and I don't know if it's always been the case or if it's just being reported more now, but rates of physician burnout and physician suicide seem to be in the media all the time now. The doctors are killing themselves. And do you think that this might be part of the reason?
Absolutely. Yeah, I think they are. I think I think we're downloading a lot of responsibility onto younger people. We are, let's add to the incredible burden to be on top of your game in healthcare. Medical knowledge is doubling ever more frequently, ever faster. You're expected to know more. You're expected to be able to do more with your hands, motor skills. You are expected to be vigilant. People don't tell you to feel good if you make a mistake. They continue to inculcate this attitude that you should be very afraid of making mistakes. Right. And add to that how competitive it is to get into medical school, and how and so it's They are overachievers,
right?
And I don't think I could get into medical school today.
Interesting.
And they are overachievers in a very big way. To me, I concentrated on my studies and I had good marks, but they have good marks are a given.
Right. That's the basic
that's
need.
That's vanilla. Yeah. To add to that, research projects and good works that you've done. Maybe you've helped build something build a clinic in a developing country. You've worked elsewhere, and this is supposed to be, I guess, instead of lived experience. McMaster still wants people who have had lived experience, who've done other things, and which I think is a marvelous way. The movement to bring arts, humanities into your early training. I think that's also helpful as well, though I think we need to see a bit more evidence. That's the kind of thing that might have been part of the curriculum 120 years ago, and now there's just no room for it today. But now you have, it's almost like survivor guilt that somebody has aspired to get into medical school. They're an overachiever. All they know is overachievement.
Right.
And whammo. They get these responsibilities and they discover that they could, orchestrate their career, tickety-boo, everything goes the way they want it to do, and then they discover patients aren't like that.
Right.
They don't talk like that. Yeah. They don't spit their symptoms out, just as I talked about with my own mistakes. And I think that, I wonder if the culture, if teachers, mentors, if everybody around them are saying you better be worth it. You better be worthwhile, because when I think of the hundreds of people who didn't get into medical school, I guess my people know about that.
Well, I was going to say, if
Holocaust survivors,
sure.
I say, parents saying to their children, "I survived the camps for this," for a child who uses drugs, and so I think that to me, all that pressure, puts younger people at greater risk of burnout. I also think that. I think there's a lot of talk in medicine about, once you get into practice, about money being the symbol of, like, income being the symbol of your self-esteem and self-worth.
Right. And
I think there's a lot of grumbling physicians, particularly in underserviced areas, rural, remote areas, that I think may be getting the message that unless I'm getting increases from the government and I'm being this is worthless.
Right.
And I'm struggling and I'm not being paid what I think I should be paid, and that's part of the dissatisfaction I think that goes into some of what you're seeing.
Sure.
And we haven't talked about exposure to trauma.
Sure. So the vicarious trauma that people must experience, or even the direct trauma of experiencing somebody who's going through these kinds of things that you see in the emergency room. How do you actually release that from yourself at the end of the day?
Well, and let's talk about when a patient dies, and let's put things in perspective. It could be worse. I could practice in Baltimore or in Denver. They refer to Denver General as the gun and knife club.
Really?
The ER there because of violent crime.
Sure.
Imagine if once every other shift I had to tell a mother that their teenage son had been shot to death.
Right.
Like I can tell you that, I've had, fortunately, a handful, more than a handful of families that I've had to tell that a loved one has died, and when it's been unexpected, sudden and unexpected.
Right.
And there's a way to do that.
Right.
I don't think we're taught how to do that.
Do you-
Maybe they're taught how to do that today, but I wasn't taught
Yeah.
how to do that. And I can tell you that it takes a lot out of me, and yet I have to run and see the next patient.
Sure. So do you numb against it eventually?
No, I've gotten better at it.
Yeah.
No, I received some very clear feedback from somebody about that.
A patient or a colleague?
No, a patient.
Really?
Yeah. No, not a patient, a family member.
Okay. Yeah.
And it was a bit indirect, but I got the message, and the message was that do it right, and they'll always remember you. Do it wrong, and they'll never forgive you.
Right.
And it's I think and this is the empathy part of it. I thought that it was I was too focused on my own distress when I was in the room with the patient, and afraid that they were going to start lunging at me and saying, why didn't you do more?
Sure.
Hey, you know what? When my father died, in walks the attending physician. My father had been admitted to hospital for just a short number of hours, I guess less than 12 hours. And he had his final heart attack. He was continuing to have chest pain. He was not operable. He was not a candidate for a bypass or for an angioplasty. He was considered too high risk, and basically he petered out. Heart rate went down. His blood pressure went down, and I wasn't even there when it happened. He'd sent us home at like 10 p.m. and like at 2 a.m. I was back seeing my father had died, and in walks the attending physician, not at my hospital, at another hospital. And he's searching my face because he thinks I'm going to lunge at him. That I'm going to start saying, "What drugs did you order? And did you consider this?
Right.
Did you consider that?"
That you're going to be a doctor instead of a son.
Instead of a son.
Yeah.
And so he was tuned into his own distress. And one of the most important lessons about empathy is that you can't empathize with somebody else, at least cognitively, if you're tuned into your own distress. Right. And so the first thing you have to do is center yourself. Try to get rid of all of the competing demands. Tell everybody that for the next half hour, this is where I'm going to be. If you need somebody else, now we have double, triple coverage, so you can say sign up to somebody else while you do it, while you have that conversation with the family, and it's all about them. And I had one really good teacher, the late Dr. Rob Buckman, who taught wrote books like I Don't Know What to Say and Breaking Bad News, and he lectured gave workshops to many, like thousands of allied health professionals, and also wrote books for families. And he said, when you're in the room with that person, you tell them so that they know, and don't use fuzzy words. Make it very clear, and from that point on, you let them feel the way they're feeling, and you acknowledge how they're feeling. And
that was one of the things I think when my mother died a couple of years ago, that she died at home. We talked to her the night before, and we knew that she had some chronic health problems for a while, but
so it was sudden.
It was very sudden, and ultimately it was labeled sudden death in epilepsy, I think, SUDEP, I think it's known as. And she had seizures in the past, and they seemed to be increasing in frequency, but nobody really knew why. And I remember distinctly the autopsy took forever because she died at home. But when she came back, it was still it was undetermined, the cause of death. And she gave a very vague kind of answer that, we didn't really find anything. We know what it wasn't. We know it wasn't an aneurysm. We know it wasn't this or that. So we've narrowed it down to this sudden death in epilepsy thing. That answer itself was entirely unsatisfactory for me because I felt like I needed an answer. But the way that she delivered it was a phone call. She was in Halifax. She spent a solid 45 minutes on the phone telling me nothing, but really just answering my questions and sitting with me in that space and saying, look, and being very honest that we don't know why this happened. And I realize that might not satisfy you, but, it is what it is. And I think that helped to comfort it.
Did she acknowledge your need to know?
She did. And I even said to her, and unfortunately I think I was self-conscious or self-aware enough to be able to say, look, I'm going to have to interrogate you for a little while. It's nothing against you. I trust you. Or I trust your credential. But I just need to do this. And I feel like she understood that.
And yeah, I might have explored that a bit gently. You know,
Sure.
the need to know to what, the need to maybe intervene,
Right.
the need and how you might have felt as a son who wasn't there, who
I think part of me in the grieving process and something so sudden like that, being the youngest, part of the intellectualization, I think, was if I figure out why it happened, maybe I can fix it.
Yes,
maybe there's still time.
Yeah. And how many siblings do you have?
I'm the youngest of three.
So now that gets to who's the fixer in the family.
Right.
You know, who the roles of the different siblings, and you have to get to know somebody enough. And you can imagine what it's like to be breaking this news without knowing any of that context.
Right.
When you're talking to a family, you better be a very quick study. But your only hope is to totally focus on them and to notice things that they're saying and acknowledge them, because at the very least they have the right to feel the way they do in that horrible moment where their life is changing forever.
And to give them the time, to not look at your watch, to not sound like you have to go, just to be there and present with them and give them the time.
So you asked, how do you deal with it?
Yeah.
By learning how to deal with it in that way, you can turn it into a more constructive experience where they remember you fondly.
Yeah.
Even though they remember that you were a nice person, that you didn't make them feel worse.
Yeah.
And so that, because one of the things I said in my book is that if you're unkind, you know it when you walk away.
Right.
And it doesn't just hurt the person you've been unkind to; it hurts you, your blood pressure, heart rate, you're one step closer to burnout.
Yeah.
So that's one of the ways that you do it. Now, after, when you go home, you talk about it. I talk about it with my partner, and I think we've had this silence, this confidentiality thing. I think we've carried it to the point of ridiculousness. You need a place where a safe space where you can talk about this, where you can have that Brene Brown moment where someone says, "Me too." Someone says, "Yeah, I did. I felt that way too," and you need to run. Meditate. You need to take negative feeling. You need to forgive yourself. I had a faux pas. I did my annual yahrzeit. That's where you say Kaddish again. You're a mourner one day every year. And I remembered afterwards that I had said one blessing wrong. I'd said the wrong thing. It was the wrong. I did the wrong time of year. I didn't flip over because I don't go to synagogue often enough to know that it had flipped over into this different prayer instead. And I was shaming myself as I was thinking about it. And then I remembered that the same rabbi who might have flinched kept saying my mother's name wrong. Kept calling her one name instead of another because he never knew her as a person. The entire time he was there, she had dementia and never spoke for herself. So when I forgave myself, I suddenly my perspective opened up, and I was able to remember that other people make mistakes too.
Yes.
And that was, to me, as fundamental a mistake as getting the prayer slightly wrong. Getting the woman he was supposed to be. I was there for the anniversary, the Jewish anniversary of my mother's death, and at the moment when we have this glass of scotch and we hope that her soul, her eternal soul, her neshama will rise higher and higher. He got her name wrong. Oh, he got her first name wrong.
Kind of interrupts the flow, doesn't it?
And I didn't point it out to him.
Sure,
I was kind to him, and I think he was kind to me too.
Yeah. So I know you have to go. What's the name of the new book?
New book is called The Power of Kindness: Why Empathy is Essential in Everyday Life.
And it's out now?
It is out, published by HarperCollins, hardcover now, softcover in end of April 2019.
Great. We'll look forward to reading it.
Thank you.
Take care.
You too.
Alrighty, that's my conversation with Dr. Brian Goldman. Go out and buy his new book. Well, it's not new anymore, I guess. It's a re-release of the paperback of his newest book, The Power of Kindness. That's available everywhere on my birthday. Don't forget, April 24th. So I'll be expecting on Twitter, on Facebook, on Instagram, lots of happy birthday wishes. You can follow me at Mark Hennick, at MarkHennick. Please head over to Apple Apple Podcasts if you liked this episode, or even if you didn't, and subscribe, so that way we can have more chances to impress you with more different episodes. We have them every single week, every Monday. Fascinating people from all over Canada, all over the world, talking about mental health, resilience, health care, as we've had a couple of guests like Dr. Goldman, and really chat about some important stuff on the show, and it's been fun to do that. So head over there, subscribe to the show, leave us a rating. A really good rating would be nice too. If you want to try out some free psychotherapy, a free trial of psychotherapy, online, safe, effective, head over to betterhelp.com/Mark. That's betterhelp.com/MARK. Enter the promo code Mark, and you can get a free trial of safe, effective online psychotherapy. Give it a try. You never know if it'll be right for you or not, so check it out. I think that's it. I think I covered all the bases here. Subscribe, rate, go to BetterHelp, like me, wish me happy birthday, please clap for me, whatever else you feel. All right, that's it. I better get out of here. This has been So Called Normal. I'm Mark Hennick. Take care.